Hi, we're back at the AATS Mitral Conclave 2015, and I'm really happy to be joined by Rakesh Suri. Rakesh is known to many of you. You've done fantastic work at the Mayo Clinic, great robotic work, which we'll talk about, and shortly you'll be joining the Cleveland Clinic. You're going to have a double clinic, clinic squared, but that's very, very exciting.
Well, it's a great work ahead.
You've done, I mean, you really have done some phenomenal work in robotic mitral valve surgery. So what's new in that field?
Great. Well, thanks for asking, Randy. It's fantastic to be here with you again. Mitral valve surgery done robotically has really come into its own now. It's been done for over a decade now. And what's new about it is the following. Number one, echocardiographic techniques have continued to evolve. So we're able to understand the pathophysiology of mitral regurgitation much better now. Number two, we understand the natural history in a much more precise way. Those two things combined, Randy, in addition with the robotic high-definition visualization and the instrumentation, that allowed us to decide when to repair the mitral valve, get up to a 99% repair rate, and now we have exciting new data saying that long-term outcomes are very, very good utilizing robotic approaches.
I mean, it's interesting. I mean, but Rakesh, you've been one of the, I mean, you had some phenomenal papers out, one that I've used a lot of times in my talks, where you say if you identify somebody with a failed mitral valve, sooner is better than later, symptomatic in a LV enlargement, but there's been some new data out on that, hasn't there?
That's right. We utilized a multi-center registry called the MEDA registry, which spans both North America and Europe. And uniquely, what we did is identified patients in normal practice who had flail mitral valve leaflets identified and essentially had severe mitral regurgitation, therefore, and then followed those who underwent surgery and mitral valve repair specifically within 3 months of the diagnosis versus those who waited more than 3 months and either were medically followed or underwent delayed repair. Strikingly, what we found is the following. There was a 60% decrease in heart failure in those who underwent early mitral valve surgery and a 40% decrease in long-term mortality. So in other words, being free of heart failure and death is much better, a much higher likelihood if you undergo early mitral valve repair.
Were these patients asymptomatic, a lot of them? Or,
yes.
Okay, and didn't have other conventional triggers for mitral valve surgery?
Correct. They did not have class 1 triggers, Randy. So in other words, they did not have symptoms or left ventricular dysfunction.
That's fabulous. Now, tell me, and that's what I was referring to, your excellent paper, but tell me about, you said you have long-term follow-up of the robotic patients, because you've done hundreds at Mayo, 400, 500 at Mayo?
Yeah, we're up to about 550 right now.
So how long is the data? How long is the follow-up, and what have you found?
Well, essentially what we did is when we took a standard surgical practice with 50 years of follow-up and then introduced new technology, the burden was on us to prove to ourselves, our colleagues, and our patients that this was a technique that was going to be good for long-term outcomes of our patients. So therefore, we instituted protocolized follow-up. I actually personally, in addition with in association with my cardiology colleagues, saw these patients back at 1 month, 1 year, and then every year thereafter. What typically happens with mitral valve repair patients, as you know, Randy, is they feel so good that they disappear into normal lives, and they feel no need to come back. Well, we've tried to get around that problem in long-term follow-up and have seen people back. What we found is the following. We found that patients do extremely well. 99% essentially have class 1 or 2 New York Heart Association functional class status. So they're living normal lives. More importantly, the recurrence rate of mitral regurgitation following robotic mitral valve repair is very low. I can't release all the data because it's going to come out at AATS 2015, but I can say it's much lower than that expected from other surgical series in the literature.
Rakesh, the question would come, how long does it take somebody to learn? And you are obviously a very talented mitral valve surgeon, And then what's the learning period, and should you initially, as you're learning, select patients so they're P2 prolapse, not complex annular disease or stuff like that? So how long is the learning period to become a proficient robotic surgeon?
In order to answer that question, I have to get to the heart team approach, because like TAVR or MitraClip, this is truly a team. It's not a robotic surgeon, Randy. So therefore, the preoperative diagnosis and quantification of these patients has to be right. Number two, they have to fulfill ACC/AHA criteria. And number three, they have to be screened with pre-robotic CT angiogram of the chest, abdomen, and pelvis. Once patients get to that level and they are seen by a surgeon and a team comfortable dealing with probably about at least 50 to 100 mitral repairs a year, then a surgeon can consider, in our view, opening up a robotic mitral valve practice. So the learning curve at that stage probably becomes about a year or two. A lot depends on how experienced the surgeon and the team is and what the tempo of those cases exactly is.
Is the complexity of the cases that you would do now, after 500 under your belt, different than what you might have done with your first 50?
Again, that's an interesting question, because for some surgeons that's true. Fortunately, in the practice that I was in, we actually had all comers. So traditionally in our practice at Mayo Clinic, 55% to 60% have been posterior leaflet, 40 to 45% bileaflet, and then depending on how you cut the data, the rest have been anterior leaflet. We have never selected based on leaflet prolapse category. Now, I'm not saying that's right or wrong.
No,
every team needs to decide for themselves what's best for their patients and what is the most honest representation of their skill set to their patients.
Okay, excellent point. Final question I would have is where do you think we're going to go in the future with the robotic approach, or with the elephant that's coming around the corner, the transcatheter approach to mitral valve disease? Where are we going in 5 years?
I think it's important that we, as a heart team, cardiologists, surgeons, and others, interventionalists in particular, don't see this as a zero-sum game. So MitraClip doesn't win at the expense of robotics, and robotics doesn't win at the expense of sternotomy. We're all in this for the patient. We put the patient first, and then our technologies circle around the patient to provide the best possible care. And I think that's truly going to be the case moving forward. These are complementary technologies. We as a heart team need to decide, and importantly, we need to get these patients to intervention. Once they come to the stage of deciding on intervention, we provide what is best for each patient individually.
So that's going to be the approach. That's the future, which is the past. Do what's best for the patient.
Yeah, that's true. Although I do think that we've perhaps been encumbered in the past with having different camps. So the interventionalists meet separately, the surgeons meet separately, and the clinical cardiologists and echocardiographers meet separately. What's unique about this meeting, Randy, is we're all here together.
No, absolutely. No, I think your point's well taken. But do you feel like that we'll see increasingly minimally invasive techniques and catheter-based techniques coming along in the mitral valves field?
I do, particularly as we're seeing the excellent results I've alluded to in the robotic space, as well as perhaps the better than expected results in MitraClip, in the percutaneous mitral milieu. So those things combined will be put forth in our clinics and in our interventional catheterization laboratories and in our hybrid suites to treat patients with the best possible options. That, in combination with this new knowledge about natural history and the deleterious consequences of watchful waiting, will, I think, bring patients to be assessed properly by heart team, and then we can stratify to appropriate therapy. So I think in the mitral space, we're going to see that there's a previously undiagnosed segment of the population which will come forth for therapy once they understand the true advantages of this ticking time bomb, severe mitral regurgitation.
And as the cardiologist gets, you're fortunate because you've got really educated cardiologists, but getting the cardiologist knowledgeable about this is really important. Listen, you've made some tremendous contributions over your fabulous career pre-Mayo and at Mayo, and I'm sure it's very exciting for you to move on in your career, and I know you'll continue to do great things. Thanks for joining me.
Thank you very much. It's a real pleasure to be with you.
Thanks.